So last week we have learned about pain, what is pain and what are the types of pain and how to assess pain. Today we are going to learn about the management part, so NSAID and adjuvants. So today we have Dr. Mary Abraham from Delhi. She is a neuro anesthesiologist and palliative care physician. She is working and a pain specialist. She is working as a visiting consultant in various hospitals in Delhi. And she has received a Lifetime Achievement Award by Delhi Neurological Association in 2017. And also she wrote a book on conquering pain in 2019. So we are very happy and lucky to have you here, ma'am. And welcome and over to you, ma'am.
Thank you so much for the welcome. Shiva, I'm seeing you after a long time. Again, it's an honor and privilege for me to take a class for the STIPS ECO program. And I understand it is for the nurses, and I'm very happy to talk to you. At any point of time, you can note down all your doubts and clarification. I'll be willing to sort it out at the end of the talk. Okay. And with these words, I would like to share my screen. Okay, 1 minute. Is it visible?
Ma'am.
So I would like to start my talk. I will be talking about pain management. Okay, the preliminaries of pain management. And the broad outline of my talk will be, I'll be talking about the basic of the WHO ladder, focusing on the step 1 and step 2 drugs of this ladder, along with the adjuvant drugs that we give at every step of the ladder. And lastly, I'll be focusing on the drugs that we use to treat neuropathic pain. Now, according to this declaration, the Declaration of Montreal, which was passed during the International Pain Summit of the International Association of Study of Pain. There was a conference in 2010 in Montreal, Canada, and in which they stated that access to pain management is a fundamental human right, which means that it is a right of all people, wherever they belong to have access to adequate assessment and treatment of pain. Now, cancer and pain. So according to the international human rights law, countries have to provide pain treatment as part of their core obligation. So it is an obligation of healthcare systems in a country to provide the pain medications. And in case it is not being given, and failure to take reasonable steps to ensure that they have adequate pain relief is actually deemed cruel, inhuman, and degrading. And in fact, cancer pain is now a healthcare priority, and the WHO has developed policies and strategies to treat it with an emphasis on total pain management. I think in the earlier talk, you might have known about what is total pain management. That means it's not just treatment of the physical pain, but also the emotional, the social, and the spiritual aspect of pain. Because in cancer, you have all these things which are intermingled to produce the total pain. So all of it have to be treated. You have to have a holistic approach to treat, not just treat the physical aspect of pain. Now coming to the WHO analgesic ladder. This ladder was formulated or devised in 1986, more than 30 years ago, based on the recommendations of a group of international experts. And after that, over the course of these 30-35 years, it has been translated into 22 languages, and it has been widely used all over the world to treat cancer. Now, what is a ladder? It is a very simple tool, it's well validated. That means it has been proved to be effective. And it is basically a stepwise approach to treat cancer pain depending on the severity of pain. Before the ladder, that is before 1980s, people were dying with unnecessary pain, especially in the terminal stages of cancer. Why was that so? That was because there was a lot of hesitation and hesitancy to give opioids. Like nowadays, we have the vaccine hesitancy. People are afraid of taking the vaccine. Similarly, those days, it was people were afraid or rather very hesitant to take opioids because they felt that they may get addicted to opioid and they will be termed as a morphine addict. So there was a lot of stigma attached to the administration of opioids. Even for those who were prescribing it were little cautious because there were a lot of strict rules. And if they were not given in the proper way, they were also subject to action by the government. So people, even the doctors were hesitant to write the morphine. And as a result of this, that step 3 of the ladder was not being used and only non-opioids were being given for pain. And there were a lot of people dying with pain. But when this ladder was devised by the World Health Organization, it actually legitimized the use of opioids. That means the WHO has given consent that you can use the strong opioids in the treatment of pain. So because of this, all these problems regarding drug regulation, stigma, etc., could be avoided. Now, before I start, let us discuss a case scenario. And in the end of my presentation, we'll see how we handle this patient. This was a 35-year-old father of 2 young children. He had a CA of the upper lobe of the lung, right side. It was a deep-seated gnawing pain, which was in the right shoulder, along with burning and tingling sensation in the right arm. He was unable to sleep. The pain score during the day was 4, but at night it went up to 6 on a scale of 10. So before we discuss what to do, let us just go through the assessment of pain, because the WHO analgesic ladder is based on the severity of pain. So to know the severity of pain, you need to assess the pain. Also, whether a adjuvant drug has to be given or not. So for that, you need to know the type of pain also. So we are all familiar with this P, Q, R, S, T, and U, by which you can assess the pain. So I won't go into details because I'm sure this has been dealt with earlier. Secondly, you also have to know whether it is a nociceptive or a neuropathic pain. Nociceptive is because of tissue injury, and neuropathic is because of a lesion in the nerves or the nervous system. So that also has to be assessed, because based on that only also you can add an adjuvant drug. So coming to the ladder, it is a 3-step ladder I mentioned. So in the step 1, it is given for mild pain. That means the NRS score is less than 4. Okay. So in this, you give a non-opioid analgesic, which I will talk about in my coming slides, along with an adjuvant, with or without an adjuvant, depending upon the associated symptoms along with the pain. Is the pain a neuropathic pain? Is there a bone pain? Or is there a colicky pain? So all these things will necessitate the use of adjuvant drugs. Now, if the pain is not responding to the step 1 drugs, then you have to go to the next step of the ladder, step 2, which is for pain that the score is around, say, between 5 to 7. It is called moderate pain. For that, we have to add a weak opioid to the non-opioid, and with or without an adjuvant drug. So the weak opioids I will talk about in my later slides. The patient is not responding to even this regime, then, or if the pain is severity is more than 8, which is a severe pain, you have to, instead of a weak opioid, you have to substitute that with a strong opioid, but along with a non-opioid and adjuvant. So you notice that non-opioids are given at every step of the ladder, be it step 1, step 2, or step 3. Okay, step 1, step 2, step 3. Adjuvant also can be added at every step of the ladder. Now, using this step ladder approach, up to 71 to 76% of cancer patients pain can get satisfactory relief just by using the WHO analgesic ladder. So what are the salient features of this ladder? We all need to familiarize ourselves with the WHO step ladder. So in this, three things you should remember, and then there are also the fourth, fifth, and sixth, but three things that you have to remember is the drugs are given by mouth, by the ladder, and by the clock. So by mouth, all these drugs are given by the oral route. That is a standard route of administration, even for the strong opioids. So this is a huge advantage. That means it can be given at home because it's given orally. It can be given by the caregiver of the patient, or it can be even given by the domiciliary nurse who's come to see the patient at home. So that is a very big advantage of giving this drugs. That means even morphine, that is a strong opioid, can be given orally. The next important feature is it's given by the ladder. That means you initially start with step 1. If it is not responding, go to step 2. If it's not responding, go to step 3. Of course, there are exceptions to this rule, and that I will discuss later, because if the patient is coming in agonizing pain, you don't go by the step 1. You may have to go directly to step 2 or to step 3. So that can also be done, but conventionally it is started at step 1 and step 2 and step 3. The third important characteristic of the WHO analgesic ladder, it is given by the clock. By the clock means it is given according to the half-life or the duration of action of that particular drug. It varies whether it is a strong opioid like a morphine. It has to be given every 4 hours because that is the duration of action of the drug. Or if it is giving paracetamol, you have to give it every 6 hours. Or if you're giving naproxen, you have to give it every 12 hours. So it all depends on the duration of action of the drug. So you have to tell the patient that you have to make a chart in which you note down the time. If I'm giving morphine, I start at 6 o'clock in the morning. Then the next dose is due at 10 o'clock. Then you have to give it at 2 o'clock. Then you have to give it at 6 o'clock. And the last dose, you have to give it at 10 o'clock, every 4 hours. This is with morphine. With paracetamol, similarly, every 6 hours. So you have to look at the clock and give the drug and not wait for the pain to come back to give the drug. That's a simple rule. Because if the pain comes and then you give the drug, the patient is still suffering in pain. And then it is more difficult to relieve that pain once the pain starts. So you should keep the pain suppressed at all times, 24 hours of the day. Another important characteristic of the WHO analgesic ladder, it is individualized to the patient. That means the right dose of drug is the dose that produces pain relief. This can vary. If the patient has, some patients, you can give a total of 30 mg of morphine a day and they're having good pain relief. But there's another patient who may require 120 milligrams of morphine a day. But it's basically, it is 120 mg that is causing pain relief in the one patient and 30 mg that is causing pain relief in the other patient. So it is all depending upon the individual patient, whether how severe the cancer is, how extensive it is, how much of tissue damage it has to cause. It all depends upon that. Okay, that varies from patient to patient. Another thing of the ladder, if you notice in the step ladder, you give adjuvant drugs at every step of the ladder. That means these drugs are added at every step depending upon what other symptom the patient has. So if the patient has got bone pain, you may have to add a separate drug, an adjuvant drug, or if the patient has a neuropathic pain, you have to add another drug. Or sometimes you have to give a drug so that you can reduce the side effects of the analgesic. So you may, adding that drug, you don't have to give such high doses of analgesic. And very last important thing is that attention to detail. Each patient is an individual. You can't say that one size is fitting all the patients. Okay. Patient's age can vary. You can be an 80-year-old person or a 40-year-old person. Again, the dose will vary. Or the emaciated, if the patient is emaciated, then you have to accordingly tailor the drug. Or if they have some comorbidities like blood pressure, diabetes, or liver dysfunction or kidney dysfunction, all these have to be taken into account when you are prescribing the drugs of the WHO analgesic ladder. At the same time, monitor the side effect profile of each drug. You should be well aware of the side effects of each drug and monitor them to see that the patient is not getting any undesirable side effects. So these things are the main features of the WHO analgesic ladder. So what are the advantages of the WHO analgesic ladder? You have seen that it is a very simple tool. It's basically got 3 steps, easily understood by everybody, including the caregiver of the patient or the nurse that is attending the patient. Then it is validated. That means it has been proven to be effective. It is also very cost effective. You know, each drug of this ladder, it's very, very inexpensive. So it doesn't involve a huge cost even to give morphine or methadone or any drug for that matter. And it can be implemented across the world, even in the underdeveloped countries. Well suited for home care, because most of these drugs can be given by the caregiver or by the domiciliary nurse. And can also be given for patients with non-cancer pain, whether it is acute pain due to a fracture or whether it is a chronic pain due to a spine disease or anything like that. Now, so you see in this drug, you can give the non-opioids at every step of the ladder, but in step 2, you add a weak opioid, in step 3, you add a strong opioid. But adjuvant drugs are given at every step of the ladder as well. Now, certain modifications of the ladder has taken place. Supposing if the patient is having severe pain, you can even omit one step and go to the next step. So you don't have to go exactly according to the ladder. It all depends upon the patient. Sometimes you may have to go directly to step 3 also. The second thing is, so I mentioned, I'll show you in the next slide, that about 71 to 76 patients don't respond to this 3-step ladder. So for that, you add the 4th step. So what is the 4th step? This was done in 2000, the modification of the WHO analgesic ladder. In this step, you may have to add, give an intervention, whether it's a pain intervention, like a nerve block or an epidural, or you may have to give a patient-controlled analgesia pump, or you may have to give a neurolytic block using alcohol or phenol to totally numb the ganglion, or you may have to use intrathecal opioids or spinal cord stimulation. So there are a lot of procedures that can be done if the patient is not responding to the step 3. And that is a small segment of patients, maybe maximum about 20-25% of patients. But the rest of the 75 patients can be treated by just using this system. So let's discuss step 1. So this is used, like I said, to treat mild to moderate pain, and the drugs are paracetamol and non-steroidal anti-inflammatory drugs, which can be combined with the adjuvant drug. So paracetamol is the name used in India and Europe, but in America it is known as acetaminophen, but they are the same compound. It acts by inhibiting the central cyclooxygenase enzyme. So paracetamol has an action on the central nervous system. It has no effect on the peripheral cyclooxygenase system. So because of that, it has got less side effects. It has basically antipyretic analgesic action. It does not have any major anti-inflammatory actions. What are the doses of paracetamol? It is safe to give at a dose of 3 grams a day. The daily dose should be less than 4 grams. A single dose should not be more than 1000 milligrams at a time. Sometimes you can give it as an infusion. You can give 1 gram every 6 hours as an infusion as well. It has a potential for liver toxicity, but still, even in patients with liver disease, you can give doses of up to 2 to 3 grams a day. In pediatric patients, you can give a dose of 15 mg per kg every 6 hours. That is safe to give in children. Toxicity occurs in doses of more than 90 mg per kg per day, or if you're giving more than 4 grams of paracetamol per day. Sometimes in patients with mouth cancer or with patients with throat cancer where they're unable to swallow, you can give paracetamol rectally as well as a suppository. What are the advantages of paracetamol? It has a very good safety profile, and the undesirable effects are not very common. It has no effect on the gastric mucosa, so it's well tolerated by patients with peptic ulcer. Unlike NSAIDs like Brufen and all, which can cause undesirable effects on the stomach as well as on the kidney and on the platelets, and it can also cause allergic reactions, which are not seen with paracetamol. Okay. And so you can see that all this is a reason why paracetamol is preferred drug to give in pain. But there are some drawbacks. The first is that there's increased frequency. You have to give it every 6 hours. So that is the duration of action of the drug. Then in patients with liver injury or with liver dysfunction, there is a potential for hepatotoxicity. That is mainly when it is given in more than 4 grams a day, when the patient already has a liver dysfunction, when the patient is consuming a lot of drinks, more than 3 drinks a day, or if the body weight is less than 50 mg, then you can restrict the total dose to 2 grams, that is 500 mg QI. So it has a very important role to play in cancer pain, and it because of its safety profile, like I mentioned, and it also has an opioid sparing effect. That means when you combine it with an opioid, you can reduce the total amount of opioids that you're giving to a patient. So that is why it is given along with an opioid. And like I said earlier, it can be added at all steps of the lab. Now coming to the non-steroidal anti-inflammatory drugs, or NSAIDs as it is commonly known as. This is very commonly used over-the-counter drug. It has got, besides analgesic properties and antipyretic, it has also got anti-inflammatory properties, which was not there in paracetamol. So indications are, it is used as a step 1 drug. It can be used mainly for nociceptive pain. Nociceptive pain is pain due to tissue injury when there is an underlying inflammation. So it can be given also for some kinds of neuropathic pain also. How does it act? I mentioned that paracetamol acts on the central COX, cyclooxygenase inhibitor, or the central COX. NSAIDs acts on the peripheral COX. That is a COX that is present in the periphery and in the tissues. Now, this is a very important enzyme following tissue injury when the metabolites are ultimately producing the prostaglandins. And it's a prostaglandins that is mediating the pain and the inflammation. So this is preventing the synthesis of prostaglandins. Okay, and that is how it is useful for pain due to tissue injury. Now, if you little bit about the cyclooxygenase or the COX enzyme, it is existing in 2 forms. One is the normal COX that is present in all tissues like the stomach or the kidney, because it is the constitutive or the housekeeping enzyme and is necessary to protect the stomach, the kidney, and also to allow platelet aggregation so that clot formation can take place. But there is another cyclooxygenase enzyme which occurs after the tissue injury. So when you have tissue injury, you have all these substances that are released called phospholipids, which are converted into arachidonic acid. Now, at this point, you have this enzyme that is now produced by the tissues, which converts the arachidonic acid into prostaglandins. And it's prostaglandins that is mediating the pain and the inflammation. Okay, now having noticed that, you now notice that COX-1 is necessary because for the maintaining the homeostatic functions. But COX-2 is actually mediating pain and inflammation. So this we should not inhibit, whereas this you should inhibit to treat pain. Now, non-steroidal anti-inflammatory drugs are of 2 types. One is the non-selective drugs. Non-selective means it's interfering both with COX-1 and COX-2. So it is preventing the homeostatic beneficial function. At the same time, it is preventing pain as well. But there's another COX-2 inhibitor, which is the selective COX-2 inhibitor, which is interfering only with COX-2. It is not inhibiting the COX-1. So the beneficial effect of COX-1 is retained, but only the pain that is mediated through the COX-2 inhibition is free. Okay. So what are the examples of non-selective NSAIDs? They are brufen, naproxen, aspirin. They're inhibiting both COX-1 and COX-2. By inhibiting COX-1, you are actually producing the side effects because the normal function is being inhibited. So you have the gastrointestinal side effects like bleeding and ulceration, or you have the allergic manifestations, or you can have adverse renal effects as well. But because it is inhibiting the COX-2 inhibition, the prostaglandin synthesis is decreased, and so you have the anti-inflammatory, analgesic, and antipyretic effect. So non-selective NSAIDs is a double-edged sword with both beneficial as well as the adverse. So what about non-selective NSAIDs? I mentioned that they're inhibiting both COX-1 and COX-2. And the examples are brufen or ibuprofen. It's given orally in a dose of 400 mg every 6 to 8 hours. Or naproxen, which is given a dose of 250 to 500 mg every 12 hours. It can be given orally or as a suppository. Now, because this non-selective NSAIDs is inhibiting the COX-1, you have a lot of adverse effects. For example, you can have adverse renal effects, gastrointestinal effects leading to bleeding and ulceration and peptic ulcer formation, or you can have allergic or hypersensitivity reactions leading to respiratory, skin, or other allergies. And also it causes decrease in the platelet aggregation, so you can have bleeding problems as well. That is not mentioned over here. Now, selective COX-2 inhibitors, they are only inhibiting the COX-2 enzyme. So it is not interfering with COX-1 enzyme. So the examples are etoricoxib or mucoxia. It is given as a once a day dose, 60 milligram, 90 mg or 120 mg. And the other one is celecoxib, which is given as 100 to 200 mg twice daily, or diclofenac sodium or voveron, which can be given orally or intravenously in a dose of 50 mg 8 hours. So the question is, are selective COX-2 inhibitors safer than non-selective inhibitors? It is definitely safe for the stomach, that is for the GI, because it is not causing any bleeding or ulceration. But where the renal damage is concerned, it has no advantage over the non-selective NSAIDs. That means if you give celecoxib or mucoxia, etoricoxib, it can cause as much kidney damage as a non-selective NSAID. But on the other hand, it has got a prothrombotic effect. The non-selective COX-2 inhibitor can actually cause a prothrombotic effect with a likelihood of myocardial infarction and stroke. Okay. Now, what are the precautions when we are using the non-steroidal anti-inflammatory drugs? Always administer a gastroprotective drug like a proton pump inhibitor, like pantoprazole or rebiprazole. Use it with caution in patients with acid peptic disease. Ensure adequate water intake. Avoid dehydration when you're giving the NSAIDs, because that can intensify the renal side effects. Also, if there's a bleeding tendency, you should avoid it. In particular, COX-2 inhibitors should be avoided in patients with heart disease or with cerebrovascular disease, because they can cause prothrombotic effects and can lead to myocardial infarction and stroke. Now, NSAIDs are also available as local gels or creams, which many of us are using, and they have producing the analgesic effect without much risk of toxicity, because there is less systemic absorption. The examples are gels which have ibuprofen or diclofenac or piroxicam or ketoprofen. So that is also widely used to treat pain. So the risk factors for NSAIDs toxicity is, for GI toxicity, you have to be very careful when you're giving into patients with upper GI symptoms or bleeding. For renal toxicity, be very careful when you're giving in elderly patients and those with dehydration, those who are already on some nephrotoxic drugs, or those whose creatinine clearance is very low. But then there are risk factors for stroke and MI, like advanced age, diabetes, hypertension, smoking. Then you should avoid using a COX-2 inhibitor. Now, coming to step 2 drugs. These are used to treat moderate pain, like I mentioned earlier, they can be combined with a non-opioid with or without an adjuvant drug. Now, step 2 drugs are weak opioids. So they are not controlled. That means you don't have to, the strict rules and regulations that are there for strong opioids are not necessarily there with weak opioids. So you give it for pain of moderate intensity that is not controlled with step 1. It is more easily available from the chemist because you don't have to fill up the special forms that you fill for the strong narcotics. And sometimes you can combine it with step 1 drugs or adjuvant. And the examples are tramadol or tapentadol. Now coming to tramadol, it is a centrally acting drug. It has got a dual method of action. That means it is first of all a mu opioid receptor agonist. It acts on the mu receptors and produces analgesia, but it is a weak opioid. At the same time, it blocks the presynaptic reuptake of serotonin and norepinephrine. So because of that, it produces pain relief. So because it's a weak opioid, there's less tendency for respiratory depression and addiction. And we can often combine paracetamol also with the weak opioid. Now coming to tramadol, it has a very high oral bioavailability. That means if you're giving orally, a lot of it is getting absorbed into the body just by the oral drug. And it is 1/10 as potent as morphine. For example, if a person is getting 100 mg morphine, if a patient is getting 40 mg morphine, it is equivalent to 400 mg tramadol. So you have to divide by 10 to know how much morphine equivalent has got the tramadol. Okay. Dose is 50 to 100 mg every 4 to 6 hours. Sometimes you have even sustained release formulation, that is tramadol SR. That means you need to give it only twice daily. It has got some side effects like nausea, vomiting, dry mouth, constipation, dizziness, sedation. And those with who are epilepsy patients with epilepsy who are taking drugs like TCA and SSRI, you have to be very careful because it lowers the seizure threshold and the patient can get seizures as well. Tapentadol is a newer step 2 drug like tramadol. It also acts in a similar way, that it's a mu receptor agonist. That means it acts on the opioid receptors, as well as it is inhibiting the reuptake of serotonin and norepinephrine. So it is acting on the descending inhibitory pathway of pain. The dose is similar to that of tramadol. So some analgesic combinations that you should use is never use 2 drugs of the same category. For example, you do not combine a COX-1 and a COX-2 inhibitor. Similarly, don't combine a weak opioid with a strong opioid. So the combinations that are good are paracetamol or NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. So these are the good combinations, analgesic combinations. Now coming to adjuvant drugs. Now, we know that cancer pain is not necessarily nociceptive, that is tissue injury. It can also be pain due to muscle spasm or neuropathic pain when nerves are involved, or bone pain or bowel obstruction, and a lot of other problems. Associated symptoms can be there. Lack of sleep, insomnia, loss of appetite, so many constipation, a lot of problems. So we need to use some adjuvant drugs as well. Okay. So why are they called adjuvant drugs? Because they have analgesic properties, but their main action is not for pain. For example, an anticonvulsant, the main action is used for seizure, but they have got neuropathic, they can treat neuropathic pain. So it can also be used for pain management. They are also called co-analgesics because they are co-administered with other analgesics of the WHO lab. They can be broadly divided as multi-purpose or broad analgesic efficacy or specific. Now, specific means adjuvant drugs that are giving for specific types of pain, whether it is a neuropathic pain or bone pain or musculoskeletal pain. So for that, you give specific adjuvant drugs. But there are other adjuvant drugs which are used for a variety of symptoms. They are called multi-purpose analgesic drugs. For example, antidepressants can be given for a variety of cancer pains. Corticosteroids, again. sedatives and anxiolytics can be given for so many types of cancer people who have got either very anxious or not sleeping well, so they are called multi-purpose drugs. Now, let's discuss a specific type of pain called neuropathic pain. Now, this can occur in 40% of patients with cancer, very high incidence, and it is because of a disease or lesion in the peripheral or the central nervous system. It could be in the nerves, it could be in the spinal cord, it could be in the brain. When there's a lesion, it produces what is called a neuropathic pain. The characteristic feature of neuropathic pain is it is either burning, shooting, electric current, or there could be allodynia. Allodynia means when just touching the patient can cause pain. Okay, that's called allodynia. So if you look at the pain, this nociceptive is because of the tissue injury that is there at the periphery. This is a peripheral nerve and this is a nerve ending. But anything beyond this, whether it is in the peripheral nerve, whether it is in the spinal cord, or whether it is in the brain, that is called neuropathic pain. Okay. So this is because of either the compression or the invasion of nerve by the tumor, or it could be even because of cancer treatment, whether it is chemotherapy or radiotherapy, or if there's surgery being done, the nerve can get injured. So treatment of cancer can also result in neuropathic pain. And it can also be seen in cancer survivors. That means the cancer is cured, but the neuropathic pain is persisting in it. So the commonly used drugs for neuropathic pain are the anticonvulsants, antidepressants, and the step 2 drugs like tramadol or tapentadol, or even opioids like methadone and morphine. So there is a neuropathic pain ladder also. In step 1, you use either an antidepressant or an anti-epileptic. In step 2, you have to use both antidepressants and anti-epileptic, along with the adjuvant if necessary. The adjuvants are added at every step. In step 3, you use what is called an NMDA receptor antagonist. That is like ketamine, drugs like ketamine. Or in step 4, you use a local anesthetic like lignocaine. Okay, depending on the response of pain. Sometimes they respond to step 1, step 2, otherwise you may have to go to step 3 step. So anticonvulsants is the first line treatment I mentioned for treating neuropathic pain. And the commonly used anticonvulsants are gabapentin and pregabalin. So the gabapentin, you must remember that they are very effective for neuropathic pain, but it has side effects like excessive sleepiness, dizziness, fatigue, and ataxia, even weight gain also can occur. So this has to be explained to the patient before giving. The other important difference between gabapentin and pregabalin, this is definitely more expensive, whereas this is lesser cost. Okay. Now, anticonvulsants. This is again the first line treatment for neuropathic pain. Antidepressants. This is a first line treatment for neuropathic pain, but the effect of the analgesic effect of these antidepressants occur in say 1 to 2 weeks time. And this occurs earlier than the antidepressant effects. And particularly it is useful in patients with cancer who already have depression, anxiety, and insomnia. So adding an antidepressant drug can be beneficial. So what are the antidepressants that are used in cancer pain? They are tricyclic antidepressants or TCA. The commonly used drug is amitriptyline or tryptophan, or serotonin norepinephrine receptor inhibitor, that is SNRI. And the commonly used drug is duloxetine, and SSRI, that is selective serotonin receptor inhibitor or SSRI. And the drugs commonly used are escitalopram. Now, the side effects of TCA include the central nervous system side effects like sleepiness, drowsiness, mental clouding, even suicidal tendency. It has got other side effects like dry mouth. It can precipitate glaucoma by raising the intraocular pressure. It can cause tachycardia, urinary retention, constipation, and orthostatic hypertension. That means a change in the position of the patient can cause fall in the blood pressure. So these side effects we must remember when we're giving the tricyclic antibiotic. So you should avoid it in patients with cardiac disease, those with prostate enlargement, and those with glaucoma. How do we give the drugs? Antidepressants are started in a dose of 12.5 to 25 mg at night, and you can gradually increase every 3 to 5 days up to 100 mg per day. Anticonvulsants, gabapentin, you can start at 100 mg, go on to 300 mg, and you can keep going up gradually. Pregabalin, you start in a dose of 75 mg, which can go up to 450 mg also. But remember, all these drugs have to be titrated for medically ill patients, especially those with renal dysfunction. What are the other drugs in the neuropathic pain ladder? They are the NMDA blockers I mentioned, and the commonly used drug is ketamine. Now, ketamine acts by blocking the NMDA receptor, which is there in the dorsal horn of the spinal cord. Okay, and that is how it is useful for treating neuropathic pain that is not responsive to anticonvulsants and antidepressants. Now, we all know that ketamine is a drug for giving anesthesia. It is an intravenous anesthetic. But in lower doses, that is sub-anesthetic doses, it can be effective for neuropathic pain. It can be given orally, it can be given subcutaneous or intravenously. It can also be given as what is called a burst ketamine dose. Okay. That means you have to give it over 24 hours using a syringe pump in the doses that are already determined. Side effects of ketamine, you will have dysphoria, the patients get agitated, hallucinations, vomiting, etc. You can prevent it by adding haloperidol or benzodiazepine into along with the ketamine. Local anesthetics acts by decreasing the neuronal excitability, and it is useful in neuropathic pain that is not responding to the step 1 and step 2 drugs of the neuropathic pain ladder. You can give this neuropathic drugs intravenously as a local anesthetic infusion, or you can even use topical anesthetics. Topical local anesthetic patches are available called lidocaine patches. They come as 5% patches and they can also be used. So remember, this can be given either intravenously as an infusion or it can be applied topically. Now, corticosteroids, they are a multi-purpose adjuvant drug and can be treated to use a wide variety of neuropathic pain. Neuropathic pain, bone pain, headache because of a intracranial tumor, or because of hollow viscous organ capsule distension, even pain due to spinal metastasis. Okay, so that is how you use corticosteroids. The usually drug we give is dexamethasone. It has got a very long half-life, so just give it once a day. Okay, and also it has got less mineralocorticoid effect, so it doesn't cause so much of sodium and water retention. So the edema is less with dexamethasone as compared to prednisolone and methylprednisolone. So this is how you give it. And always give a gastroprotective drug like a proton pump inhibitor when you're giving steroids to prevent the adverse gastrointestinal side effects. You can use baclofen for treating neuropathic pain with spasticity. For bone pain, you can use a variety of drugs like corticosteroids or NSAIDs, or you can use bisphosphonates and denosumab, or you can even use palliative radiation. Calcitonin used to be given, but then recent studies show that it is not very effective in treating bone. Now, these are some of the drugs that are used to treat bone pain, that is zoledronic acid, which are called bisphosphonates, or you can use drugs like denosumab as well. Okay. We can also use palliative radiation to treat bone pain and decrease the pain due to occurring due to the metastasis. So these are some of the nucleotides that are given to treat bone pain due to bowel obstruction. You can use steroids to decrease the edema in the bowel. You can use a somatostatin analog like octreotide, or you can use an anticholinergic drug like hyoscine butyl bromide or glycopyrrolate, or even steroids like dexamethasone. They all act by decreasing the intranumeral secretions in the gut and inhibiting the peristaltic movement, and thus causing relief of the pain due to bowel obstruction. Some of the other adjuvant drugs that are used are some skeletal muscle relaxants, or you can use some antibiotics, or if the patient is very agitated and hallucinating, you can use a neuroleptic like olanzapine. You may have to use anxiolytics, sedatives, so there are a whole lot of other adjuvant drugs. Now, coming to this gentleman who had the pain, we have to do, first of all, a comprehensive pain assessment, and you have to also take a psychosocial and a spiritual history as well. Very important to treat pain in a holistic way. Now, with this particular patient, we know that he had only pain of 4 and 6. Okay, so the pain was mild to moderate. The type of pain was a combination of nociceptive and neuropathic. Nociceptive was because he had the gnawing pain in his shoulder, and neuropathic pain because he had the burning pain in the arm. The temporal nature of pain, that is, what is a variation of pain during the day, it was worse at night. And then, unveiling the meaning of pain, we found that he's a father of 2 young kids, he's unable to sleep, unable to work. So there were a lot of functional, emotional, psychosocial concerns as well, and financial concerns. So that could also be aggravating the pain. So how do we treat this particular patient? We can use step 1 drugs, because in the daytime, the pain was just around 4, but you can add an adjuvant drug to treat the neuropathic pain and the insomnia. So in this particular patient, you can add paracetamol NSAIDs along with a gabapentin or a sedative at night as well. And then very importantly, we have to address the psychosocial concerns for this patient so that his financial and social concerns are also addressed. To summarize, the WHO analgesic ladder is a sheet anchor for cancer pain management. Okay, you can treat up to 75% of patients with just using this ladder. It can also be used for non-cancer pain. Its main advantages are the simplicity and the easy implementation. And very importantly, it has legitimized the use of the opioids in the management of cancer and non-cancer. So now I'm going to stop screen sharing. Is that okay?
Okay, ma'am. Thank you. Thank you for the excellent presentation. Anybody have any doubts regarding these topics? Please ask. Anybody? Or you can put your questions in the chat box too.
Any doubts or clarifications or anything that you have not understood? Feel free to ask me, or you can even write in the chat box, whatever you need.
So they said everything is clear.
Sorry, ma'am, I have one question.
Yes, please.
On step ladder.
Tell me.
Patient pain assessment, we can assess by score, yeah? Am I right?
Yes.
If the patient's pain is third ladder, how I can clarify score?
No, can you tell that once again?
I want to know if the patient's step ladder is 3, patient's pain score number, how is it? Should be more 7 score or?
See, I said that the analgesic, am I audible?
Yes, ma'am. Yes.
So the analgesic ladder is applied based on the intensity or the severity of pain. Okay. So if the pain score, if the patient is saying that my pain score is 3 out of or 4 out of 10, that means I give the step 1 drug. Okay.
Step
But if
one
the patient,
drugs.
if the patient says my pain is moderate pain, that means between 5 to 7. Okay, that is moderate pain. Then I will add a weak opioid, that is step 2 drug. If the patient says my pain is 8 to 10, that means very severe, unbearable pain, then I will add the step 3 drug. This is how
Thank you, ma'am.
and then decide which how you want to, which analgesic you have to give.
I see. Thank you.
Anything else? Thank you for asking the question. Are there any other doubts? Please feel free to ask. Okay. This is a time you can clarify all your doubts. If you have a good interaction, everyone else will also benefit. Okay, not only you, even other people will benefit. So please ask. As far as between Sheba and I, we will try to answer your questions.
Yes, I'm Gabriel.
Very good. Tell me.
Yeah, my question is, my colleague I just asked, I want to know, you said if the patient score is 3, you go to step 1. But
I haven't understood. I haven't understood your question. Can you tell that one?
Are we there?
Tell me once again.
Yes, I'm trying to say this, the prescription is ready, the patient is on step 3. And then with the time goes, the pain score is reduced. Can the patient be moved back to step 1?
You mean to say that after step 3, giving the step 3 drugs and the pain score reduces, can you come back to step 1? That's what you're trying to say, right?
Yes, that's what I'm trying to say.
Yes, you can, because sometimes, the patient is having some severe problem, and then you're giving pain is very severe, and you have to go up to giving morphine. That is step 3 drug. But at some point of time, that problem settles down and the pain is very well controlled. You can come down the ladder as well, no problem. You come down to step 2 and then to step 1. Okay, there is no problem. It all depends that if there's something that has aggravated the pain, and once the pain is controlled, you can come down the ladder. Yes, that's very good question. Thank you for asking that.
Hello, madam.
Yes.
Yeah.
Joe,
madam.
tell me.
Thanks. Yeah, thanks for the opportunity. Yeah, I am working in a HIV palliative hospital in Patna. So I have doubt that we are getting the cryptococcal meningitis patient. So that headache and the pain is related to mental, and sometimes it means not regularly. It's a severe pain. Sometimes it getting worse, and after that it's something like that mild pain. It's fluctuated pain. Okay. So in this situation, we are counted it. It's like a step 2, or it's going step 1 like that. This is sometimes it's getting worse, and sometimes it's fluctuating pain. So that is my question. So we can go for opioids, or we can SOS like that. That's my question.
You're talking of brain involvement. Is there brain involvement?
Yeah. Is cryptococcal meningitis? Yeah.
So that means there could be headache, means because there's a raised intracranial pressure, right?
Yeah.
In such
Sure.
patients,
Yes.
it's better to avoid morphine.
Okay.
Opioids are very cautiously given in patients with raised intracranial pressure, because opioids can cause a slight respiratory depression, and that can increase the carbon dioxide levels in the blood, and that can worsen the intracranial pressure and cause more headache. In fact, it can even cause coning of the patient, and the patient can even become unconscious. So please avoid giving strong opioids in patients with intracranial tumors or intracranial lesions. Okay, so in such patients, steroids are very beneficial, Kijo. You can give drugs like dexamethasone, because that can reduce the I don't know, because steroids itself can cause cryptococcal meningitis. Hai na? One of the
Yeah,
common cause of
we
cryptococcal
are,
meningitis is giving steroids, right? Huh? But
yeah,
if
we
the,
can, yeah, the steroids also it's harmful to cryptomeningitis.
yes, yes. So
So
in that
we are
case,
using
you do not.
tramadol. Yeah,
So
yeah.
tramadol is better than giving a strong opioid like morphine. Okay.
Okay.
Pain is fluctuating, then it all depends upon the baseline pain and the incidental pain that is happening, right? So
Yeah.
to the baseline
Yes,
pain, you
yes.
can give something round the clock, whether it is step 1 or step 2 drug, and the intermittent SOS doses you can give for the incidental pain. Avoid giving opioids
Okay.
in patients with intracranial tumors or intracranial involvement.
Yeah.
Cause a worsening of the pain and worsening of the headache and worsening of the intracranial pressure inside the brain. Okay.
Good afternoon, ma'am.
Okay. Thank you, madam.
Welcome. Kusum, tell me,
Good afternoon, ma'am.
PhD scholar.
Yes, ma'am. I am working in palliative care, ma'am. Ma'am, I have a query. I'm working with the gallbladder cancer patients. Like those who are suffering from gallbladder cancer, then opioid is not indicated drug for them for severe pain. So, what could be the option for these kind of patient who are suffering from severe pain?
See, why are we not giving opioids for gallbladder is because it causes the constriction of the duct, right? That is why you're afraid of giving. But I think if a patient has got severe pain due to gallbladder cancer, you can give morphine. I don't think it is contraindicated in that patient. You can still give opioids, strong opioids to treat gallbladder pain. At that time, you're not so worried about the constriction of the sphincter and things like that. You're not worried about it. And if because the pain is because of so much of a tissue injury and the spread of the gallbladder cancer, that if the pain is very severe, more than 8, I think you can still give a strong opioid for that patient. I don't think it is contraindicated.
Thank you,
Hiba,
thank you so much, ma'am.
what would you say to that?
Ma'am, good afternoon, ma'am. Hello, ma'am.
Yeah, Rajesh.
Yes, ma'am.
Yeah.
Ma'am, actually, I want to ask one question because since it is dealing with the drugs, so what about the dependence status and tolerance? The patient, if particularly if a patient having a drug addiction or longer term of this type of drugs, how it can be treated?
See, there's a difference between physical and psychological dependence. Okay.
Yeah.
Now, physical dependence is anytime you give a drug like an opioid, it has to be tapered off. You cannot stop it suddenly because it can cause withdrawal symptoms.
Yeah.
So if you're giving, that is called physical dependence. Okay.
Yeah.
It is a normal thing. If I take opioid, I may not be addicted to opioid, but if I stop it suddenly, I will get withdrawal symptoms. But if I taper it off gradually, I will not get withdrawal symptoms. That is called physical dependence. Now, addiction is psychological dependence. That means there's a craving for the drug. That means despite the side effects, you're going on taking more and more of the drug. Okay. And that happens when I am either there are some psychological reasons, or I have a drug history of drug abuse, or if there's a family history of drug abuse, then you have some psychiatric disorders, then you can have a craving for the drug. That is psychological dependence, and that is pathological. But physical dependence is not pathological. Okay. As long as I taper off the drug, there is no problem. I can take that morphine.
Okay, madam. Right. Thank you, madam.
Kalaimani, do you have any questions? So here on questions regarding morphine, next week we have a session on morphine. That time we will discuss more about that. So
Okay, now all clear, no? Everything is clear? No other doubts?
Yes, ma'am. We can go to the case presentation. So, Ms. Antonia.
There's a question in the chat box, Shiba. Score of pain is the best method to determine the quality of pain. Now, there's a difference between quality of pain and the severity of pain. Okay, just remember PQRST. P is the provoking and factors. R is the radiation. S is severity of pain. And then T is a type of pain. So the quality of pain means the type of pain. But S is for the severity of pain, that is the intensity of pain. So if you ask the type of pain, the pain can be sharp pain, it can be a burning pain, aching pain. So that is different. But intensity or severity means how bad the pain is. That means each pain, whether it is a burning pain or whether it is a pricking pain, is it mild, moderate, or severe? Is it the score is 3 or 4 or 5 or 6? So there's a difference between the type of pain and the quality of pain. The type is the quality of pain, severity is the intensity of pain. There's a difference between the two. Okay, and WHO ladder takes in the severity of pain, not the type of pain. Type of pain is to know whether it is a neuropathic or nociceptive. That is different. But the WHO and its step 1, step 2, step 3 drugs are based on the severity of pain, not the type of pain. Okay, there's a difference between them. Is it clear?
Yes, ma'am. Can we move on to the patient story, ma'am?
Yeah.
One more question. For psychological dependency, shall we use placebo drugs?
Shall we use placebo drugs? No, I don't think there's a role of placebo drug.
Oh,
You can't treat pain with a placebo drug. Okay, pain is pain. If
yes.
the patient says, I have pain, we have to believe the patient that he has pain. And we can't fool the patient by giving placebo drugs. Okay. How long is a treatment for morphine? It all depends upon how long the patient has pain. If the patient has pain for 6 months, you have to give morphine for 6 months. As long as they don't show any side effects and the patient is tolerating the morphine well, you can continue with the morphine, no problem. There is no limit for that. Okay.
So morphine related questions we can discuss next week. This
The lecture is on morphine and all, so you
yes.
can all.
Okay, we can move on to the patient story. Ms. Antonia Kamante from Uganda will be presenting a patient story today. Ms. Antonia, welcome and over to you.
Thank you. Can I begin?
Yes.
Please.
Yes.
Okay. My name is Antonia Kamate at Kundane. I work as a palliative care. I am a palliative care nurse, but currently I'm also working as the site manager at my place of work. My organization is Hospice Africa Uganda. Next slide. So the patient I'm discussing today is a 53-year-old woman, and she has a diagnosis of cancer of the cervix in stage 3, and she's also HIV positive. So the presenting complaint she came with, she came to our facility on the 19th of January this year, and she told us that she has lower abdominal pain, which has been there for 4 months, and also lower back pain for 2 months. And she had a foul-smelling vaginal discharge, which was thick, and she described it that it was brownish in color. So this is how it all began. She went to a district hospital on the 8th of November last year. And when she went there, she was complaining of lower abdominal pain for 1 month, abdominal vaginal discharge. While at the hospital, she was diagnosed to have syphilis and a urinary tract infection. They treated her with benzathine, ciprofloxacin, and nitrofurantoin. She got some relief, but she came back for review on the 22nd of November last year. And this time she told them new symptoms. She said that she is already menopausal, but she's seeing vaginal bleeding. This time she was referred to the regional referral hospital for a cancer of the cervix screening. And when this was done, the findings showed, or the findings of the VIA test were positive, and they noticed that the cervix had been eaten by a mass and it was involving the upper third of her vagina. A biopsy was then taken and the patient was sent to our facility at Mobile Hospice Mbarara, where I work, for assistance with the biopsy processing and palliative care. She was enrolled on our palliative care program. So the reason she was sent to us from the hospital is because we have a program that can support financially the processing of biopsies, which is a challenge for most of our women. So when the biopsy was processed, the results show that she had a moderately differentiated invasive squamous cell carcinoma. Then we sent her back to the hospital for staging, and they staged her at stage 3A. On examination, generally she was an independent lady, able to perform all activities of daily living on her own, and she was well kept, she was clean and tidy. Her vital signs were within normal range. She had a pulse of 92 beats per minute, blood pressure was 120/84, temperature 37.6, and she had a mid-upper arm circumference of 24.5. There was really no abnormality detected on physical examination, and we did not do a vaginal examination because it had already been done very well at the regional referral hospital. We moved on to assess her pain. She had two physical pains, the lower abdominal pain, which at the time we met her was now 4 months old. It was piercing, and on a scale of 5, she rated it at 4/5. She said this pain is constant. She said that that pain was relieved by step 1 analgesics, and that pain would affect her sleep and mobility when she was not having those tablets. We thought that the possible cause is tissue damage in the cervix due to cancer. Then for the lower back pain, 2 months old, it was a deep-seated bone pain in the lower back. She rated it at 2/5 on a scale of 1 to 5. This pain, she reported it was intermittent. It was made worse when she moved. When she would do any work, it would hurt, but when she would not be moving up and down, she would feel some relief. She also said that this pain was relieved by step 1 analgesics, and this pain affected her sleep and mobility when she didn't have tablets. And we thought the possible cause of this pain was probably referred pain from the cervix to the back. So what we did, we gave her, for her lower abdominal pain, we gave her paracetamol, 500 milligrams tablets, so 2 of those 3 times a day. Then for lower back pain, we had tablets of ibuprofen, which are 200 milligram tablets. We gave her 2 of those 3 times a day. Then for the false smelling vaginal discharge, we gave her uncoated metronidazole tablets, those which are not sugar coated. Here in Uganda, they look yellow. And the sugar-coated ones look pink. So we don't advise the sugar-coated metronidazole. We give uncoated metronidazole tablets, which come in 200 milligrams. So we advise her to insert her vagina 1 tablet twice a day, in the morning and in the evening. We did the biopsy processing, and we saw that she has a moderately differentiated invasive squamous cell carcinoma. Those are the medications as mentioned above. Next slide, please. Psychosocial aspects. This woman is a widow. She is HIV positive and has been on antiretroviral therapy for 10 years. She did not bring her documents from the HIV clinic, so we were unable to ascertain which antiretroviral treatment she's on and when she started, but Through her report, she said she has been on antiretroviral treatment for 10 years. She is educated up to primary 4 and is able to read and write in the local language. She is a subsistence farmer, and that's where she gets the main source of income from the sale of farm produce. Here in Uganda, everything has been converted into a cash crop. So you can sell your beans, you can sell your peas, you can sell your millet, everything. So that's how she gets money, bananas, pineapples, whatever you have that can be food can be sold and you get some money. Her main caregiver is her son. She has 7 children, but she lives now with only 2 of her youngest children. She has a daughter of 16 who is going to school and a son of 18. All her other children are married and they have their own homes. They are independent. They do not stay with her. She lives in a brick house with iron sheet roof. She uses solar power for lighting. Her house has 3 rooms. She collects water from a well close to her home. She worries a lot about the future of her daughter. She has not disclosed her cancer diagnosis to her family. Maybe to put it a bit in context, the reason why she is worried about her daughter's future is because the daughter has to be married and go and live with the husband. The land on which they are on basically will have to stay with the youngest son. So she's anxious about her daughter's future getting after knowing this difficult diagnosis. And she has not yet told her family about the cancer diagnosis. So on our part, we need to support her to come to terms with that cancer diagnosis. We need to encourage her to share that diagnosis with her family because she will need their support in future when they are undergoing radiotherapy. Also, we need to continue giving her regular reviews before she finally goes to the capital city for radiotherapy. And even after radiotherapy, we will continue providing her support as she comes for reviews at our health facility. The main concern is that she has now developed a comorbidity. She already has HIV and now she has got cancer of the cervix. And this cancer is advanced. Stage 3A is quite advanced. Another concern is that there are delays to start radiotherapy. And this may reduce the chances of her benefiting from the radiotherapy. Another concern is a false-smelling PV discharge, and this can lead to depression and self-isolation. So in summary, this patient was enrolled on our palliative care program. We took care of her, processing her biopsy, and we managed her pain on step 1 analgesics. We were able to treat the false-smelling PV discharge, which made her more socially able to mix with people, go for functions like church and parties without being embarrassed. We provide regular reviews as required. So we give her review dates for follow-up, monthly, weekly. Right now, we are still trying to fix her in to travel to the city for the radiotherapy. In the meantime, she comes for review and replenishment of the tablets. We will provide for her to go to the National Referral Hospital for radiotherapy, which is in the capital city. While she is there, the nurses at our site in the city will continue to visit her and make sure her stay in the city is as comfortable as possible. We own a hostel specifically for women who go for radiotherapy treatment. This we do with the support of friends in Canada. It was a real problem because, radiotherapy, you get a dose once a week and people cannot travel from the capital city back to their villages and back to the capital city. So they have to stay in the city until they have got all their doses of radiotherapy. So we were able to get a hostel and own it. And so all the women we send to the city after radiotherapy, they have a place to stay for free. The challenge we have is that she has really delayed to go. As I speak, she has not yet gone, and we met her in January. Yeah, so that is something that is challenging, but we are doing all we can to make sure she goes. So I was thinking what we could discuss together as a class is what more we can do as nurses for this lady to improve her quality of life. And then also I was thinking we could discuss about, since we look at holistic management, what other support can be given to her that is not particularly a nursing intervention. Thank you for listening.
Thank you, Antonia, for the wonderful presentation. Anybody have any more clarification regarding this patient story? So, otherwise, we can move on to the discussion points. So I hope all of you are clear. So I would like to hear from the participant side, what more we can do for this patient? How can we improve the quality of life of this patient? Already we have learned about what is palliative care. The main aim of palliative care is to improve the quality of life of the patient and their family and to relieve pain. This is the most important aim of the two important major aim of palliative care. So we understand the patient story, we go through the patient story. So just think about how we can improve the quality of life of this patient. Hariharan, you want to say something? Anyone?
Good afternoon, ma'am.
Ma'am. Yes.
Ma'am, to improve the quality of life for this patient, because that physical pain is somehow addressed, but patient can have some psychological pain because their caregivers, they don't know about the status of this patient. So according to my opinion, we can involve their caregivers so that her quality of life and better compliance to treatment also can be better if we will involve their caregivers, like their daughter or son who will be with her. They can be involved, so other issues can be addressed for this patient.
Thank you, Kushum. So definitely we will ensure the other aspects of pain too. So that is one good suggestion. So Antonia, I have questions whether the patient is got adequate pain relief with ibuprofen. Did she get? Yeah.
It's interesting because we have been seeing her since January, and when she has enough paracetamol and brufen, she's not complaining. She seems to be comfortable, so we did not want to start morphine yet. I think there are some women who have very, I don't know whether you say a high pain threshold or a low pain threshold. They can withstand a lot of pain, and when they get some relief, they are very grateful and they don't want any more. So we wait for the time that they say, really help me and give me something more. Then we know it has gone high. And because we believe what the patient says, even if they say it's on 4/5 on a scale of 1 to 5, we record that as they have said it. But when we give treatment as a starting and we see they are comfortable, we continue like that. So sometimes it is tricky, but that's what happened. And up to now, we have not yet started her on morphine. She seems comfortable, and yet the impression on report was that it was really severe.
Okay, thank you. And also I would say you have to add a gastroprotector along with the ibuprofen. There is no gastroprotector.
Yes.
So you have to add one of the gastroprotector so that we can avoid that side effect.
Yes, thank you. True.
Madam,
Yes. First of all, Antonia, this is a very nice presentation. You've given a very detailed presentation. Thank you so much. You've taken a lot of pains to make this presentation. Okay. The other thing is, like Kusum said, yeah, we need to treat this patient holistically. Okay. That is, and holistically try to improve the quality of life, like Shiva mentioned. The physical part of pain has more or less addressed. Yes, definitely this lady has got a high threshold for pain. When a patient has high threshold, they're able to withstand more pain. Okay. So this lady, because of maybe her suffering and the fact that she's brought up so many children on her own, definitely they are very resilient kind of women, you know, and that is why she must probably having a high threshold. The physical aspect has been taken care of, but we need to address the other aspects. That is the psychological, the social, and the spiritual aspects of pain. Okay. Now, where psychological pain is concerned, you know, like because of her foul smelling discharge, she can be withdrawn and withdraw to herself, and social isolation can be there. It can make her feel anxious and depressed. So we need to, you know, find out whether how depressed and anxious she is. So there are various scales to even that, you know, there are for scales to monitor the anxiety and depression level also. And then, you know, by adding an antidepressant drug, you know, we have various antidepressants that can be used to treat neuropathic pain. So they can treat anxiety, depression, insomnia also. So they're very beneficial in cancer patients. So there is no harm in adding an antidepressant to her treatment regime. Did you mention something about the sleep? Was the sleep disturbed, Antonia? You're muted, please.
She said that her sleep was disturbed, but when she has the tablets, she can't sleep. When they run out, then she can't sleep.
Which tablet are you talking about?
Paracetamol and ibuprofen.
No, but then, so you know what? If your sleep is disturbed, you will have more pain the next day. Sleep lowers the threshold of pain. Okay, so it's very important that she's not sleeping is because probably she is anxious, she's depressed, she's having psychological issues which can cause her lack of sleep and insomnia. Because if it is not the pain, then it is the other issues that are causing her the insomnia. Insomnia itself can aggravate your pain. So you have to treat insomnia by giving maybe antidepressants. That will be very beneficial for her. So you can start her on some tryptamine or amitriptyline. Okay, that will benefit her. Or you can give her a simple sedative like lorazepam also, whatever is available in your setup. But it's very important that she sleeps well during the night. Okay, that is also an important issue that we need to address where pain management is concerned. Okay, and then of course, like her children are almost adults. One is 16 and one is 18. So I think, you know, she should be able to take them into confidence as well, so that they understand what their mother is going through, rather than keeping it to herself. You know, when you keep it to yourself, you know, you have a huge burden. Whereas she can, by confiding in them and by venting out her feelings, she can get a lot of relief. They will understand why their mother is having so much of a problem. So she needs psychological and spiritual, psychosocial support as well, whether it is from her relatives or whether it's from her children. That needs to be addressed, because she's already living under the cloud of a HIV. And then on top of it, she's getting a cancer also. So she must be definitely going through a lot of emotional turmoil, which needs to be addressed as well. And then, of course, spiritual reasons. We have to know, you know, some of them will start questioning God, finding out why are they being punished? You know, is it God punishing them for their past misdeeds? That is one of the common causes for spiritual pain. Is why am I suffering? Is it because of something wrong that I've done that I'm being punished this way? So we need to, why am I living? You know, these are the questions that people ask when there is spiritual pain. And so we need to give them a lot of assurance that, we are there to support you, and pain is not a punishment for your past sins or your misdeeds and things like that. So we need to take care of those issues as well. And we are giving her paracetamol. So we may have to add, maybe the step 1 drugs are good enough, but you can add an adjuvant drug like an antidepressant, maybe a sedative, and then of course a psychological support that she may require. That's also very important. And the scale you mentioned is out of 5. So I'm not very familiar with that scale out of 5. Normally it is out of 10. The visual analog scale or the numerical rating score is generally out of 10. So we need to clarify that is it out of 10 or is it out of 5?
We use 1 out of 5 because that's what I found them using when I came to work in hospice. Okay. But also taking the person through the process of identifying the pain from 1 to 10, some would get lost on the way and not understand.
Okay,
so
okay.
The scale, the quicker they would understand. But there are also some, she was a bit educated, she could read and write, but there are some who don't even understand the scale. So for some patients, we don't even record that.
There is another scale called the pain faces rating scale. Okay, there are about 5 faces there, in which one is a happy face, one is a sad face, one is a crying face. And depending on that face also, you can rate the pain if they cannot tell it on a scale. Sometimes scales are very difficult to understand. Okay, in India, what we do is, we tell them that if 1 rupee is 100%, how much of a rupee pain are you feeling? So I don't know in Uganda what coin you have, but if you say that your basic unit of currency, say if it is $1, then you say out of $1, how much are you feeling? Is it $0.50 or is it $0.25? That also you can say to make them understand how much pain they have. Because scales may not be understood by everyone. You can either show them the faces scale. It's called the faces rating scale. Wong and Baker faces rating scale. Okay. Or you can show out of a rupee. In India, we have a rupee. So 1 rupee means 100% pain. Half a rupee means 50% pain. 5 out of 10. So based on that, there are simpler ways of asking them to tell what their pain is. So any other questions? So I feel to this regime of paracetamol and Brufen, we can add a proton pump inhibitor, but it will be good to add an antidepressant as well. Start off with amitriptyline in a dose of 10 mg, and you can slowly build it up to 25, 50, or even 100 mg. That will help pharmacological treatment of depression as well. And as well as sleep. Sleep also needs to be addressed. Okay. That is how you're improving the quality of life of a person. The foul smelling discharge has to be addressed, which you are doing it by giving metronidazole. Okay. So these social issues also need, otherwise she'll be socially ostracized by her society. People may not want to visit her. Her children also, will. So that needs to be addressed. These are the things that need to be addressed to make that lady feel that she's once again accepted by her family and her friends and her relatives. And maybe there are spiritual concerns. Is she a religious person? Is she not believe in God? Or does she feel that God is being unkind to her or being cruel? See, these are the issues that also need to be sorted out. Okay. You know the origin of the word pain in Latin or something, it is peona, P-E-O-N-A, and peona is meaning punishment. So the origin of pain was punishment for the sins. Even now, people think that it is a punishment, I'm getting for if I'm having pain.
Thank
Any
you
other
very
questions?
much.
So I think no more questions. Can we wind up the session, ma'am?
But there was some couple of questions on the chat box.
Oh, okay.
I think one was about liver problem. If you're giving more than 4 grams of paracetamol a day. Now, a person with liver disease or liver dysfunction, earlier the impression was do not give them paracetamol because it can aggravate liver dysfunction. But even if they have liver dysfunction, you can give paracetamol, but in less than the normal doses. Up to 2 to 3 grams a day you can give, even with liver dysfunction. Okay, it is not absolute contraindication. So you can give maybe, but definitely 4 grams and all you only give with patients who have good liver function. But if patient even has liver dysfunction, you can give 2 to 3 grams a day as well. So what is the body weight of this lady, Antonia? Approximate body weight of the lady?
I did not weigh her, but I think she's between 55 and 60.
Yeah. It's very important to weigh the patients, okay? Because all your drugs you're giving will be based on the kilogram body weight. Like the dose of paracetamol is in 15 mg per kg every 6 hours, okay? Or the dose of whichever drug you want, Voveron or anything. So it's very important to know whether they are emaciated, in which case you have to come down on the drug, or are they adequate body weight? So her body weight seems to be adequate. She's neither obese nor is she emaciated. Okay. At some point of time, you can also know whether she has got any liver dysfunction or kidney dysfunction. Then accordingly, if they have kidney dysfunction, you will avoid NSAIDs. And if they've got liver dysfunction, then you avoid, I mean, you have to maybe avoid morphine also, but you may have to give lesser dose of paracetamol. So it is good to know the underlying function because she's a known case of HIV. So maybe at some point of time, you have to gauge also what her kidneys and her liver and all are working in proper functioning. But body weight you must take in all patients. Okay, that's very important.
So one more question, ma'am. Can more than one sedative be given in 6 hours?
See, sedatives generally have to be given in the night, okay, so that they get a good sleep. You don't have to give sedatives in the daytime. So why do we want to give it 6-hourly sedative? Usually we give it in the night only. If I want to give a lorazepam or I want to give any other drug, if it's a psychiatric medicine, that's a different thing. But if you're giving sedative so that they can sleep well at night, and it's usually a once-a-day dose. Very rarely you have to give it more than once a day. Only if the patient is very agitated and all, you may have to give it. Otherwise, generally it's given once a day.
Okay. No more questions, I think, and we can wind up the session. So before wind up the session, I would like to add a few points regarding NSAID. Madam had given a detailed session on the NSAID adjuvants and weak opioids and all. So we all nurses, we are not an authorized person for prescribing drugs, but we should give that appropriate advice to the patients. Okay, and we should keep it in mind what all the side effects will be there for each drugs, and we have to do the proper assessment. Okay, when the patients come for a follow-up, you have to do the proper assessment whether they have any side effects, whether they have any toxic effect and all. If patient start on NSAID, there are 3 important points we should tell the patient and the relatives. So one important thing is they need to take the NSAID after food. So that is one important after food, they should take NSAID. And the second thing is they should drink more oral fluids. Okay, so one NSAID can cause acute renal failure. So that is very, very important. If possible, they should drink adequate oral fluids. And another important thing is you have to add a gastroprotector. So any gastroprotective drugs they should take. So if the doctor forgot to write that gastroprotector, you have to go to the doctor and tell him or her to add a gastroprotector. This is the three things. Is very, very important. When a patient starts with an SAD, you have to make sure that the patient is having these all things, and you have to do give a proper instruction to the patient and the caregivers too. So this much I want to give it to you all today. Thank you for the excellent presentation, ma'am, and thank you all for making this session is very interactive. Thank you once again. Thank you. See you next week.
Thank you.
Thank you all. Thank you, Mary ma'am, for a wonderful presentation, and thank you, Shiba ma'am, for being with us. And everyone, please do fill that feedback link. I have shared it in the chat box, and it will be shared in the WhatsApp group also. So please go through it and fill it out. And thank you all. Hope to see you all on the next class. Bye bye.